The first speaker is Professor Major General Mrs. Sagarika PATYAL, and she'll be speaking on OCT in glaucoma patients.
Good morning, and welcome to the people who have come to hear us. And I'm going to make OCT as the way I understand it and the way I put it to clinical practice. So this is, as he said, it's basically for a comprehensive ophthalmologist. The first question that arises in our mind is, why do we need an OCT? Why should I do an OCT for glaucoma diagnosis? We all know that the ganglion cell complex is the first part of the structural part to be affected in glaucoma. Now, mind you, it is the OCT which detects that and keeps us alert. It is not that we're going to treat the patient, but the moment we see, okay, there's one structural damage which has occurred in the ganglion cell complex, we immediately, our antenna are raised. Patients who cannot perform fields, so many of us find patients like that. Then how do we record damage? How do we record that there is progression? That is only by means of OCT. So basically, it is used to create a foundation for our diagnosis of glaucoma, progression of glaucoma. So it provides an objective, quantitative, accurate, precise, reproducible measurements of three structures which are extremely important to us in glaucoma diagnosis. That is the optic nerve head, the retinal nerve fiber layer, the macular substructure. Now, there is software that is so important for us. Software which can be used to measure change over time. That means progression can be noted to detect whether there has been a progression in the disease. So we also therefore have a statistical data which is available, a software which is available, which determines whether the structural features of optic nerve head, RNFL of a given individual, whether it falls within the normal range or there is statistically significant difference that has occurred over time. The most important thing I feel whenever anyone is buying any OCT is check what is the normative data. So in the OCT which we are using and which I'm going to describe in detail to you all, it is the RTVU. This was the first OCT which had come up in the United States and it's used extensively in India too. It has a very good database, clinical data of approximately 10 clinical sites worldwide. So there were 555 eyes which were enrolled in the study. Mean age group was 49.5. Range was between 18 to 82. Now, mind you, this becomes a huge problem because children who are below 18, and many of them are coming to us now for detection whether they have glaucoma or not, we have no database. But we can always record it and then follow them up over time. Ethnicities have been Asian, Hispanic, Caucasian, and African American. Now, what does the RTU scan? The optic nerve head, the ganglion cell complex. It also gives us the macular scan to tell us about what has happened to the ganglion cell complex. The first thing we must determine is what are the tips for obtaining a good OCT. So for that, first choose the right scan protocol. Remember that if you choose a fast protocol, it minimizes motion defects. Adjust the scan position. That means the patient should be sitting properly. The scan's ring should be absolutely around the optic nerve head. Check the signal strength. And if it is, I will talk about this, in case you find that the patient has got a dry eye, please put in artificial tears. Ask the patient to blink properly, but do not blink during the testing. Check if there are black areas in your scan. That means there's missing data. Please have a look at the signal profile analysis, the RNFL thickness quadrants, sectors, everything should be checked. Please check correlation with the visual field. And most important, have a look at the clinical data and involve the patient. Tell the patient, look here, as this is very good. Explain everything to the patient too. Please do consider the cost. Do not do it for a patient who does not require it. Do not do it at 6 monthly intervals. Makes no sense. Do not rely on the colors. I've seen green, I've seen yellow, and therefore this is all right. No, that's not the correct thing. Please look at the numbers. Clinical examination is an absolute must. Also remember that it is not just the RNFL which you have to look at in glaucoma diagnosis. Please have a look at all the things. All the information is there for you. Please take in all that information. That means whether it is GCIPL, whether it is the circumpapillary RNFL, please have a look at the optic nerve head. So all the tissues which have been affected by glaucoma should be taken into the OCT, into your consideration. So as we get set, go for the glaucoma diagnosis, look at the signal strength, motion artifact. Have we acquired a proper image, and also access raw data? Be like your retina colleagues. Please go and have a look at the OCT, whether it is correct or not. So the first part of the information in the printout is age. Very, very important, because it is comparative. Explain to the patient, you must give your age, because it is being correlated with the normative data. Examination age, date of birth, as I've said already, and patient's registration number. Now, first important thing is quality of scan. Now look at, this is the RTVU scan. Now I have marked in a please can I have a pointer? So you can see that there is a yellow color, a red colored mark out here. And this is the signal strength. At the bottom I've written there's 41, and as per this it is 25. Now remember that if you look at the first scan, that is this one, this is the scan of the GCC. Now that is the ganglion cell, macula. In this, you find that it is only 41. Why is it 41? Because the patient is looking straight on. Therefore, you get a very good image. On the other hand, when you're looking at the optic nerve head, what do you tell the patient? Look a little on the side. So when you're looking at the side, at that time, the iris comes into view, and therefore, automatically, your signal strength decreases. Now, this is the signal strength in all the types of printouts is not the same. This is of the Cirrus OCT. So whereas in the case of OptiView, it is the manufacturer has said 40 is the signal strength that we should take into consideration. In the case of Cirrus, it is 7. Now where is the 7? You have to hunt for it. It's right at the top. Just look at this at the top over here. So please hunt for that. Before you look at the printout, look at the signal strength. Now we come to spectralis OCT. In this, it is the signal noise ratio. Now this is of 15 decibels. Now this is again, where is it present? Again, it is present at the top. So we find that this is something that you all must look at before we go on to the actual examination of the OCT. So if you find your image quality is unreliable, subpar, inaccurate data acquisition is there, it confounds the image interpretation. So if you've got a very, very weak image or a soft image, then in that case, the software is unable to accurately identify the boundaries of the layers being able to measure, it is wanting to measure. So therefore, you will get it leads to an improper clinical diagnosis and decision making. Therefore, reduced scan quality reduces tissue thickness. I will show you one example. Simple methods. First of all, make the patient understand the test, blink before the test, instill artificial tears. Remember that every eye has typical microsaccades per second. So unless you have image tracking, motion artifact will be very likely even with the most cooperative patient. So accurate acquisition of image without cutoff at the image edges. I will show you examples with good centration of the optic nerve and the fovea is very important. Now this was a young girl around 15 years old being followed up as a glaucoma suspect. Now look at the scan which we have taken. This is the first scan. And with the first scan, we found that suddenly, oh my, it is 41.8. So can I continue? I've got a little left. Yeah? So 41.8 is too less. We repeated it and we found that, okay, it's become absolutely fine. Again, the GCC shows the same thing. So now you look at the way the scan is being placed over here. See, this is improper. It's a 3.4 millimeter diameter, but it is not properly placed. You have to look at the termination of the optic nerve border. Look at the segmentation. And then after that, have a look at the hourglass pattern that comes over here. And you can first of all only see that the red and yellow is telling us that yes, the nerve fiber layer is very good. Again, you must know that there are 12 radial lines which are being taken, and the NRR thickness is being measured. And don't look at the red and yellow, but please have a look at the numbers. Now look at this one and look at this one. Hourglass pattern, all the numbers are present sector-wise, and you can come to know. Remember that the RNFL thickness does change with age. Normal, it is 95.4 approximately. In Indians, it's 100. Early glaucoma, it becomes 80. Advanced glaucoma, 70. There is definitely an RNFL decay with age. You must look at every sector. Don't just go by the entire quadrant because you will miss certain factors. And you must not forget this entire chart that I've given over here. Area of the disc is extremely important. Cup and rim is very important. Average retinal nerve fiber layer thickness is very, very important. So early defects, one small car can be missed. Therefore, you must have a look at all the figures. And the parameters which are extremely important for glaucoma diagnosis: vertical rim thickness. Please look at these figures, very important. Rim area, vertical cup disc ratio, and in the GCA, the inferotemporal sector average, superotemporal sector average, and the inferior sector ganglion cell complex. Extremely important figures that you must not miss. Therefore, I go back to it. So area of the disc is extremely important, cup and rim. And now we come down to RNFL thickness map. So now the two of them are placed in the normative data, and you find that one is a big line, which is telling us, okay, it's present in the normative data, whereas the blue line is definitely below. Therefore, there is a definite difference. Remember, asymmetry is the hallmark of glaucoma, and this itself is telling us asymmetry is definitely present. And this, the ganglion cell complex, as we know that whenever you do a ganglion cell complex, don't forget to look at the macula. There may be concomitant macular disease. You can have macular edema, you can have epiretinal membranes and ARMD. Then you'll get fooled. So once you do it, you find that first of all is the thickness map. This is the RTVO map. And then after that, how much is the deviation? All the ones that you can see in black is how much it is deviated from normal. What is the statistical significance? And you find the whole thing is in red, highly statistically significant. Therefore, remember, in the RTVU, we have one figure which is very important, the FLV. That is, if your FLV, the focal loss variance, is a very important figure which tells us whether the patient has glaucoma or not. Now, I'm asking you all, should this figure be repeated? Please have a look at the signal strength. Very, very poor signal strength. Have a look at this matter over here. See, there is loss of data. And if there is loss of data, remember, it's going to be extrapolated. Remove this, please repeat it again. Now, this is the way we always do of the glaucoma change analysis or progression. And in this, it does, if there is progression, is if there's 10% loss is significant, if it is confirmed on the second visit. This is, mind you, of the RNFL. GCC, similarly, if you find that there is a loss, see, you can see the loss out here beautifully. So we have already taken a good OCT. I'll just give you one example. I've got plenty, but I will give you one example. 53-year-old male, high myopia, no other risk factors, CCT normal. You find that the right eye has a huge defect. And then if you look at the OCT, we find that what is important for you to understand is that the optic disc area is extremely low. See, it is 1.12. Now, you all know that Indian eyes varies from about approximately 1.5 to approximately 3.3. But here it is very low. Look at the rim areas. So this is going to give you an indication that, yes, this man has glaucoma. 19-year-old male, referred for glaucoma opinion. Just have a look at the retinal nerve fiber layout here. Also look at the optic cup. Everything is absolutely normal. But he has a small defect in the right eye in the visual field. If you look at the defect also in the GCC, in the retinal nerve fiber layer here is the defect, and also in the GCC. Is it glaucoma? No, he had an optic disc pit. 51-year-old male, he was on metoprolol. If a patient is on metoprolol, remember his intraocular pressures may be absolutely normal. He had open angles, his IOPs were normal. He had a huge, almost like a hemifield defect. And when we did his OCT, we find that there is a huge defect in the RNFL as well as in the GCC, signifying that, yes, and of course the huge amount of asymmetry, signifying that the patient has properly glaucoma. 81-year-old male, hypertensive, diabetic, bilateral pseudophakic, on lots of medicines with, again, we find that this patient definitely has. Please do not forget to look at the SSIs, the signal strengths. There's asymmetry, left decreased, superior and inferior, RNFL decreased. And please remember, the FLV, although should be able to tell us whether this patient has glaucoma or not, it is only borderline. So the entire OCT has to be taken into consideration with what the findings are. Now, I will go on to the last one, which is very, very important. 43-year-old lady, diabetic, hypertensive, bilateral aphakic, pathological myopia. Please have a look at the fundi, and you find that there are a huge amount of pathological myopia out here. Remember, high myopics is not added in the database of patients. Therefore, you cannot, the software is inadequate. It cannot. Also very important is, please have a look at this figure. See, there is missing data out here. So it's going to be extrapolated. There's missing data out here. It's going to be extrapolated. Therefore, in myopes, you have to be very careful, and OCT is not going to be greatly helpful. Again, the same things I've shown, and that's about it. Thank you very much. Yeah, I'm sorry I've taken so much time, but there was so much of information. Thank you.